Hey guys, so today we're going to be covering Chapter 17, which covers cardiovascular emergencies. In this chapter, we're going to review the circulatory system as far as the anatomy, physiology, as well as pathophysiology of it as well. We'll cover what acute coronary syndrome is and what cardiac compromise is. We'll cover the medications that we use for chest pain for cardiovascular issues such as nitroglycerin, as well as some age-related variations that you'll see between pediatrics and geriatric patients, as well as how do we assess and care the patients. We'll also go over some general guidelines when assessing these patients as well, and then we'll summarize it all together at the end. During this lesson, you'll learn about assessment emergency care for a patient suffering from cardiovascular emergencies such as chest discomfort or pain and cardiac arrest. Heart disease is one of the leading causes of patients having any kind of chest problem, which is in actuality America's #1 killer. So because of the potential consequences that patients may have because of heart disease, we want to treat any patient that's presenting with signs and symptoms of cardiac compromise as a cardiac emergency. The circulatory system has three major components, and each of these components can play a significant role in patients experiencing a cardiac-related emergency. The heart, which is the muscle of the cardiovascular system, is what pushes blood and pumps blood throughout our entire body. Blood vessels are what transports. It's the actual subway, I guess you could say, or tubing throughout our body that it allows for the blood to go to various portions of the body as well as coming back to the heart. Arteries, these carries blood from the heart to the body. Your blood vessels transports blood from the body back to the heart, and your capillaries is what bridges the gap. And this is actually where the perfusion and transfer of oxygen to the cells actually takes place. And then you have your blood. The amount of blood somebody has, it depends on the size of the person. And a general fully adult-sized male who weighs approximately, we'll say, 200 pounds, that person would have roughly about 5 to 6 liters of blood. Within your blood, you have plasma, which is the actual fluid or medium of your blood. You have red blood cells. This is actually what gives the plasma that red tint to it. In your red blood cells is actually what's called hemoglobin, and this is what actually carries oxygen to the body. So if you cut yourself, if you see bright red blood, that means the blood is oxygenated. If it is dark red blood, then it is deoxygenated and you have a venous bleed. Within the blood, you also have what's called white blood cells. This is part of your immune system. It helps fight infections. And then you have platelets, which is part of your clotting factor. We'll cover these more in detail as we go along. Your conduction system is, the heart has its very own conduction system, and the heart is one of those awesome things that it has its own basis of automaticity. It is where it's able to actually create its own impulse that stimulates contraction of the muscle cells with no need of communication with the brain. So you could actually decapitate your patient's head, be decapitated, and the brain completely severed from the neurological system, where now there's no neurological stimuli going to any muscle within the body, but the heart continues pumping. Your primary pacemaker of the heart is the SA, or sinoatrial node. If the SA node is firing properly, the patient has a normal heart rate, and their pulse is generally about 70 to 80, 90 beats per minute. If the SA node fails, let me go to this, that we all can see where I'm at. If the SA node fails, which is your primary pacemaker, it then goes to the AV node. It goes down the conduction pathway that's composed of cells and that neither initiate an impulse nor contract. Instead, the cells of the conduction pathway rapidly conduct each impulse to the rest of the heart muscle. And they do this in a kind of a unified fashion so that rather than the whole heart contracting at once, there's sequential contraction of the chambers. So SA node fires, it causes contraction of the right atrium. It then sends that signal down the pathway to the AV node. Okay. If the sinoatrial node fails, it then goes to the AV node. If the AV node is the primary pacemaker, now your pulse is out about 60 beats per minute. From there, it goes down the Purkinje fibers. Okay. And down down the bundle of His to the Purkinje fibers. The AV node, if it fails, it then goes to the bundle of His. If the bundle of His is the primary pacemaker, your pulse range is normally about 40 to 60 beats per minute. Once it fails, now we're down reliant on the Purkinje fibers, which is what causes contraction of the ventricles. Now your pulse is down at about 10 to 20 beats per minute. If it gets down to this point, the patient does not have a very good likelihood of surviving. Now the heart's activity is monitored by the body to ensure that it's meeting the body's blood flow requirements. If the heart's activity needs to be modified, assistance is provided within the autonomic nervous system. Now, who can tell me what the sympathetic and parasympathetic nervous systems do that influences the heart? How does it influence the heart? Right. It can cause the heart to contract more. It can cause the heart to speed up or slow down. Okay. The sympathetic branch of the autonomic nervous system innervates all three pacemaker sites and the working cells of the heart. When the body needs increased blood flow, the sympathetic nervous system is stimulated and causes the heart to beat faster and with greater contractile force, which thus increases the ejection of blood. The parasympathetic branch of the autonomic nervous system, it innervates the sinoatrial and atrioventricular nodes. When the parasympathetic nervous system is stimulated, it slows the heart rate and eases the force of contraction. Now the right side of the heart, when blood comes in, it's receiving the deoxygenated blood from the venous system and then pumps it to the lungs for oxygenation. The left side of the heart receives oxygenated blood from the lungs and pumps it to the body. Now, if the pressure in the pulmonary vessels is low, thus the right ventricle does not need to generate a great deal of force to eject the blood. In some pulmonary diseases, such as emphysema, however, the pulmonary vessels are compressed or narrowed. This increases the pressure in the pulmonary vessels and makes it much more difficult for the right ventricle to pump the blood out. Now, if this high pressure is sustained over time, the right ventricle begins to weaken and eventually can fail. This is referred to as right-sided or right ventricular heart failure, also known as cor pulmonale. The pressure in the aorta is high. Therefore, the left ventricle must generate a significant amount of force to eject the blood against this pressure. Now, if the pressure in the aorta is excessively high, as seen in severe hypertensive patients, or if the blood pressure is simply higher than normal over a long period of time, the left ventricle will begin to weaken and fail. Also, if the left ventricle muscle is damaged due to a blockage of a coronary artery, the ventricle weakens and cannot pump an adequate amount of blood out of the left ventricle, which thus can cause heart failure or left-sided heart failure. Now, the heart consists of four chambers. You have the left and right atrium, which is hidden. And then you have the left and right ventricles. Now, the heart has only one purpose, which is pumping blood within the body. If that single purpose is interrupted even momentarily, cardiac arrest ensues, and the chance of survival for these patients is very slim. Your arteries carry oxygenated blood to the arterioles and then to the capillaries, which interface with cells throughout the body. The exception to this rule that arteries carry oxygenated blood is the pulmonary arteries, which carry deoxygenated blood from the right ventricle to the lungs to be oxygenated. Your veins carry deoxygenated blood from the capillaries, where the blood has picked up carbon dioxide and other waste products given up by the cells. Um, it then goes to the veins and back to the right ventricle. Again, the exception to the rule that veins carry deoxygenated blood is the pulmonary vein, which carries oxygenated blood from the lungs back to the left atrium. Now, within your circulatory system, within the vessels, there's multiple different types. It actually gets, the name changes because as the blood comes out of the aorta, it's a very big tube, and as it goes down the body, it gets smaller and smaller. So it'll start off as arteries, and then as it continues to get smaller, it turns into arterioles. So these would be down near, so when we palpate a radial pulse, you're actually feeling on the radial arteriole. Then you get to the capillaries, which the walls of capillaries are actually thin enough to allow for the movement of gas, nutrients, and waste products between the blood and the tissues. It then after it passes through the capillaries, it then goes up through the venules, and as you go up the body, the vessels get bigger and bigger and bigger until eventually you get to the veins. Now, who can tell me what the first organ or first thing that gets blood is? No, it's not the brain. It's the heart. The heart makes sure that it is taken care of before anything ever gets perfused. So when blood comes out of the left ventricle, comes out into the aorta, the very first thing that breaks off is into the coronary arteries, or the arteries that surround the heart. So the heart makes sure it gets fed, and then the blood then continues on from the aorta down into the arteries, and so on and so forth. Let's see. If a large coronary artery is blocked, it cannot supply an adequate amount of blood to the heart muscle. Eventually, if the occluded coronary artery is not open or unblocked, that portion of the heart muscle becomes hypoxic and begins to die. Because that portion of the heart is actually deprived of oxygen. So that, just like any other muscle within the body, this will cause anaerobic metabolism to occur. Okay, so you have that lack of oxygen, you have anaerobic metabolism, you have lactic acid beginning to form. This can be caused by a heart attack and a clot forming within a coronary artery. Heart failure or an abnormal cardiac rhythm could occur either because of the occlusion or led up to the occlusion. So as the heart or blood is coming out of the aorta, as you can see, the very first artery that it comes in contact with are your coronary arteries. Okay? These are the same arteries that are associated with many cardiac emergencies that we will see. And as you've progressed through this program into advanced and even into paramedic, you'll get a better understanding of this when you do your cath lab rotations. As mentioned earlier, the blood is composed of several components that serve multiple functions for the body. The serum or plasma or liquid portion of the blood is that transport medium for the formed elements. The formed elements include the red blood cells, which among other functions carry oxygen to the tissues of the body. You also have white blood cells that serve to protect the body and eliminate infections from virus and bacteria. And then you have platelets, which are cellular elements whose job is to help in the clotting process to attempt to stop bleeding. The normal clotting mechanisms of the blood can form a clot in a coronary artery that is damaged by plaque. The clot may be partially or completely occlude the coronary artery, thus cutting off or reducing the supply of oxygenated blood to the heart muscle. The heart muscle will eventually become deprived of oxygen and may begin to die. So as you can see in this, you have plaque beginning to form here. Okay. As it continues to form, you have those fatty streaks that's beginning to form. Once that gets to a point, you have fibrous plaque that forms, causing further vessel damage and causing resistance to blood flow. And then eventually plaque deposits begin to ulcer or rupture, and that causes platelets to aggregate and adhere to the surface of the ruptured plaque, thus causing clots that may nearly or totally block the passage of the artery. Let's see. We already went over this. The cardiac contraction. Um, so when an electrical pulse is created, like I said earlier, it's generated within the SA node. It travels through both the right and left atria by way of the Bachmann bundle, and both atria contract simultaneously because of this electrical impulse. The impulse then travels to the AV node by way of an internodal tract located in the area between the atria and the ventricles. There the impulse is inhibited briefly to allow the blood from the contracted atria to fill the ventricles. And then the impulse travels down to the bundle to the left and right ventricles via the left and right bundle branches. From the bundle and the left and right bundle branches, the electrical impulse travels to the Purkinje fibers, which are embedded in the ventricular muscle, causing the ventricles to contract simultaneously. Now, the electrical activity of the heart is actually represented on an ECG as a series of waves that correspond to electrical events in the heart. The wave or deflections of a normal ECG have three portions: the P wave, QRS, and the T wave. We detect electrical activity. Obviously, we cannot put electrodes in on the heart, but we put electrodes on the skin surface that is able to pick up the electrical activity, which is picking up the depolarization and repolarization of the heart. Now, the P wave is the first waveform on an EKG and represents the depolarization or contraction of your atrium. The QRS complex is the second waveform and represents the depolarization or contraction of the ventricles and the main contraction of the heart. The T wave is the third waveform and represents the repolarization or relaxation of the ventricles. Now, the atria also does have a repolarization wave, but it's usually hidden within the QRS complex. If you see this wave, it could be indicative of some type of issue going on within the heart. Another portion of the EKG is called the PR interval, also referred to as PRI. This is measured in terms of time and used for analysis of the EKG. The PRI is calculated from the beginning of the P wave to the beginning of the QRS complex, and it represents the time it takes the heart's ventricle impulse to travel from the atria to the ventricles. Now, we won't cover this in detail in this course. If you go all the way through paramedic, you'll learn more in detail of how to read an EKG. Now, if the heart muscle can become hypoxic, injured, or even die. Your electrical conduction system can also be damaged or disturbed and cause the improper functioning of the heart. Sometimes these conditions produce an irritability of the heart that causes the uncoordinated firing of electrical ventricular impulses called premature ventricular complexes, or PVCs. When PVCs occur in succession, they can produce ventricular tachycardia, or VTAC, which displays on an EKG as steep peaks and valleys that are close together. If left untreated, ventricular tachycardia can degenerate into ventricular fibrillation, or VFib, which shows up as a smaller, uneven, disorganized peaks and valleys. Now, blood pressure, this is the amount of pressure exerted against the arterial wall during circulation. A smaller sized vessel offers greater resistance, thus resulting in a higher pressure. Thus, vasoconstriction increases vessel resistance and blood pressure. Now, the systolic blood pressure, or the top number, this is measured during contraction of the heart and is a measurement of the amount of pressure on the vessels during contraction. Diastolic blood pressure, this is measured during relaxation of the heart and is a measure of the amount of pressure on the heart during rest. Inadequate circulation is what eventually will result in hypoperfusion or shock. Now, the delivery of oxygen and nutrients from the blood through the thin capillary walls into the cells, and the removal of carbon dioxide and other wastes is known as perfusion. So, shock or hypoperfusion is a chief result of inadequate circulation, thus causing a profound depression of cell perfusion. This can be caused by multitude of different things, such as deoxygenation, metabolic conditions, hypovolemia, vasodilation, heart failure. You name it, anything can actually cause a patient to go into shock. Now, when a patient is having any kind of cardiac issue, time is a critical element in the survival and improved outcome of many of these patients. Death of a portion of the heart muscle is permanent and irreversible. Thus, it is important for you as an EMT to recognize the signs and symptoms of the many possible cardiac conditions referred to collectively as cardiac compromise, and to provide emergency care and expeditious transport to a medical facility that is prepared to manage a patient with such a condition. Some of these patients might be eligible for drugs such as fibrinolytics or antiplatelet agents, or mechanical therapy or angioplasty that can actually destroy the clot and restore blood flow to the heart. The sooner these therapies are delivered, the less the damage that can occur to the heart, and the better the prognosis of the patient's outcome. Arteriosclerosis is a condition that causes the smallest of arterial structures to become stiff and less elastic. This is often referred to as hardening of the arteries. Atherosclerosis is a form of arteriosclerosis, the development of plaque within arteries, which can lead to narrowing of the arteries and reduction in blood flow to the heart. Now, the inability to deliver increased blood flow is to the myocardium when it is needed causes ischemia of the heart cells, which may result in chest pain or discomfort called angina pectoris. Acute coronary syndrome is a significant disease and is a very significant cause of death in the United States. Early recognition of signs and symptoms and early intervention are keys to reducing death from ACS. Acute coronary syndrome results from a variety of conditions that can actually affect the heart, in which the coronary arteries are narrowed or occluded by fat deposits or plaque, clots, or spasming. The words acute and syndrome refer to the sudden onset of symptoms from coronary artery narrowing or occlusion. Chest discomfort or pain that is a result of heart muscle ischemia is referred to as ischemic type chest pain. If you ask the patient if they have chest pain, they might answer no. More often, the patient feels more of a crushing chest pain that is described as dull and aching, and not necessarily as pain. The pain or discomfort can be localized to the area of the sternum and radiate to the jaw, arms, shoulders, or back. Now, angina pectoris is caused by is due to a reduction of oxygen delivered to the heart. Now, a complete blockage of blood flow through a coronary artery results in ischemia and death of myocardial cells. Myocardial ischemia can result in chest discomfort or pain. Rest to reduce the heart's oxygen needs and nitroglycerin to relax the smooth muscle in the coronary arteries to dilate them usually relieve classic angina. Angina pectoris usually occurs when a patient is undergoing some type of emotional or physical stress. A decrease in oxygen delivered to the myocardium, which is often caused by partial blockage of the coronary arteries, which causes ischemia that results in tissue hypoxia. So this is that ischemic heart muscle, and once this dies, which is what ischemia means, that area of the heart will never be able to function properly again. Now, unstable angina has a variety of definitions, but usually indicates angina discomfort that is prolonged and worsening, or that occurs without exertion and when the patient is at rest. Characteristics of unstable angina can include pain or discomfort that occurs at rest, continues without relief, or is prolonged. If the patient experiences angina that occurs at rest and lasts for more than 20 minutes, angina with a recent onset that progressively worsens, or angina that wakes the patient at night, also known as nocturnal angina, you should view it as an acute coronary syndrome emergency and provide prompt treatment and transport. Classic angina is typically relieved with rest and nitroglycerin. If the classic angina following exertion is not relieved after rest or after 3 nitroglycerin tablets or sprays over a 10-minute period, you should recognize this as an acute coronary syndrome emergency and provide prompt treatment and transport. Now, by saying that, does it mean that even if somebody took nitroglycerin and it was relieved that they shouldn't be evaluated? No. If they had chest pain and they took nitro and it was relieved, they still should be evaluated. If not in the emergency room, at least at their primary care physician. Get some lab work drawn up, make sure there was no damage to the heart. When treating patients that have angina, we want to administer supplemental oxygen. Definitely if the patient is dyspneic or hypoxemic, has any obvious signs of heart failure, or has an O2 sat of 94% or less, or if the O2 sat is unable to be evaluated. Initiate oxygen therapy via nasal cannula at 2 liters per minute and titrate the concentration and liter flow to achieve and maintain an SpO2 of 94% or greater. If the patient has prescribed nitroglycerin and their systolic pressure is greater than 90 millimeters, place them in a sitting or lying position and administer the nitroglycerin tablets or spray. If the patient is suspected of suffering from a coronary artery occlusion, administer 160 to 325 milligrams of aspirin if local protocol allows it. And then consider contacting advanced life support and be prepared to manage a cardiac arrest patient. Now, why did we want to administer the aspirin? No, we're not giving it to them for pain. No, we're not giving it to them for fever. We're giving it to them for the anticoagulant factors of it. So that way we can try to prevent further coagulation of the blood, further clotting of the blood. Now, a myocardial infarction is the severe narrowing or complete obstruction of the coronary arteries. Will result in death of myocardial cells if the blockage is not quickly reversed. Ischemia of myocardial cells can thus result in potentially lethal dysrhythmias. Rarely, a heart attack can also result from a spasm of the coronary artery. This can be caused by use of a sympathetic stimulating drug such as cocaine. If the blood flow is not restored to that portion of heart muscle, the cells begin to die. Ischemic heart tissue can become irritable, which thus produce abnormal beats in the conduction system that can lead to dysrhythmias. Some dysrhythmias, such as ventricular fibrillation and ventricular tachycardia, can be fatal. Signs and symptoms that a patient will have with AMI might include chest discomfort that radiates, dyspnea, the patient has a sense of impending doom, nausea, vomiting. Now, the classic signs and symptoms of myocardial infarction are not present in all patients. Some may have one where the other doesn't. Also, diabetics, the elderly, and women are more prone to an atypical presentation of symptoms when suffering a heart attack. Many might suffer what's called a silent MI, in which no chest discomfort is experienced. The only complaint they may have is of shortness of breath, lightheadedness, weakness, or nausea. Now, chest discomfort is the most significant symptom of a heart attack. That is the, stereotypical symptom that patients will have. The discomfort the patient experiences is similar to that of angina. However, the symptoms last longer. Also, chest discomfort from an acute myocardial infarction will usually be only partially relieved with nitroglycerin and if not relieved at all. The boundaries between unstable angina and AMI are not so distinct, and it can be difficult to distinguish between the two conditions. That's why it's important for these patients to be taken to the hospital for evaluation. These patients also have the potential to go into cardiac arrest. Therefore, you should frequently assess the patient and maintain a vigilant watch over their condition. Your AED must always be available and close to the patient. Ensure your patient has a patent airway, and then provide positive pressure ventilation with oxygen connected to the device if breathing becomes inadequate. If it is adequate, just administer supplemental oxygen if the patient is dyspneic, hypoxemic, or has signs of heart failure. Initiate oxygen therapy via nasal cannula and titrate to maintain an O2 sat of 94 or greater. Try to keep the patient in a position of comfort. If they have nitroglycerin, you can administer 1 tablet every 3 to 5 minutes, up to a total of 3. Be sure the systolic pressure is above 90 and remains above 90 following each nitroglycerin administration. If protocol allows, which in the state of Alabama it does, administer 160 to 325 milligrams of aspirin. If you do have a suspected MI, notify the receiving hospital quickly. And the reason you want to notify them is that way they can go ahead and get their cath lab team activated. Now, most hospitals, they're going to want a copy of that 12 lead. So we want to transmit the 12 lead that we acquired to the receiving facility. Excuse me. Continue to assess your patient, and if needed, call ALS if further assistance is needed. Aortic aneurysms occurs when a weakened section of the aortic wall, usually resulting from atherosclerosis, begins to dilate or balloon outward from the pressure exerted by the blood flowing through the vessel. An aneurysm can exist for a long time with no symptoms or signs that the patient is aware of. And then suddenly, pop, and rupture, causing rapid and fatal internal bleeding. Usually an aortic aneurysm occurs within the abdominal region. If you ever go to palpate an abdomen and you feel a pulsating mass, stop. That patient has an aortic aneurysm that is prepared to rupture. And we'll cover aortic aneurysms later on in this program. Now, aortic aneurysms, this is that at beginning. It's beginning with that pulsating mass. Usually, if the patients have an aortic aneurysm, there will be pain, especially in the back. And when the aneurysm gets large enough, perhaps shortly before rupture occurs. Usually the aorta can't be felt with a physical exam, but at the final stage it can be felt as a pulsating mass in the abdomen. So it'll continue to pulsate, continue to get bigger and bigger and bigger until finally it ruptures. Now most of these patients, if they actually have a ruptured aneurysm, unless they happen to be on the surgical table when it occurs, they have a very low likelihood of surviving. Now, aortic dissections occur when there is a tear in the inner lining of the aorta and blood enters the opening and causes separation of the layers of the aortic wall. Aortic dissections occur most often within the thorax. The pain is classically most severe when the dissection first occurs and is most often described as a sharp, tearing, ripping type pain. So you have that tear in the inner lining and it's beginning to enter into the middle layer of the dissection, or of the vessel. Depending on the location of the dissection along the aorta, it can cause symptoms similar to a stroke or a myocardial infarction and can even lead to damage to the heart. Whether you have an aortic aneurysm or dissection, um, you're going to treat it for the most part the same. If a pulsating mass is felt and you do suspect that aneurysm, administer oxygen and transport the patient immediately because, as I said, surgery can prevent or repair a rupture of the aneurysm. For chest or back pain that can result from an aortic dissection, or that can be a symptom of myocardial infarction, administer oxygen and assist the patient with prescribed nitroglycerin if their pressure is more than 90 and no signs of hypovolemia are present. If you suspect an aortic dissection, do not administer aspirin. In females, the death rate for females who suffer heart attacks is much higher than males when the event occurs. So you want to make sure that you have a high index of suspicion for ACS or acute coronary syndrome when gathering a history from the female patient. They'll have those. They may have those classical findings such as the dull chest pain or discomfort, nausea, vomiting, and diaphoresis. But more often, they're going to have the non-classical findings. So you want to err on the side of caution on the side of the patient and provide emergency care for a potential MI or ACS despite a presentation of atypical signs of ischemia or infarction. Also note that diabetics and elderly are also high-risk groups that can present with atypical findings, such as that tingling in the fingers, pain in the back and upper abdomen, neck pain, unexplained fatigue or weight gain. So want to make sure that's why you do a good history on your patient. Oxygen was previously thought to be helpful to all patients in all situations. Based on current research, oxygen still does have tremendous benefits. However, it is also clear that oxygen can be harmful and increase the amount of cell damage and death in certain situations. One such situation is within acute coronary syndrome, in which a coronary artery has become occluded and cuts off blood supply to a distal area of heart tissue. This area of tissue thus becomes ischemic from the lack of oxygenated blood. During this period, there is an inflammatory response in the vessels of damaging molecules made from oxygen, which are referred to as free radicals. The restoration of blood to an area of tissue that was ischemic from low blood flow or occlusion of a vessel is called reperfusion. The oxygen in the blood flowing to the reperfused tissue increases the production of oxygen-free radicals. The free radicals directly damage cell membranes and other cellular components and result in cell death. This is called reperfusion injury. In managing the acute coronary syndrome patient, it is necessary to reverse any hypoxia. However, it is also extremely important while reversing the hypoxia not to deliver more oxygen than is needed to avoid creating unnecessary cell damage. Therefore, it is recommended that oxygen be provided only to acute coronary syndrome patients with an O2 sat greater than 94%, or if an O2 sat is unknown, if the patient is dyspneic, hypoxemic, or has obvious signs of heart failure. Heart failure can be categorized as left ventricular heart failure or right ventricular failure. The consequences of left or right ventricular failure can be understood by recalling the functions of the two sides of the heart. Cardiogenic shock can result from the combined pumping inadequacy of both ventricles or from either the left or right ventricle. Left ventricular heart failure can lead to pulmonary edema. When the left ventricle fails, the cardiac output drops and there is diminishment in the perfusion pressure to the rest of the body's organs. Common findings do include a drop in systolic blood pressure, to include frank hypotension, diminished or absent peripheral pulse amplitude, altered mental status, changes in the heart rate, poor urinary output, respiratory distress, inspiratory rales, and possible pulmonary edema. Left ventricular hypertrophy, or enlargement of the heart muscle, comprises the ability of the left ventricle to pump adequately, thus causing a decrease in cardiac output and a decrease in blood pressure. Okay? Is that left ventricular hypertrophy? This is how it should look. Okay. As hypertrophy continues to form, the muscles become larger, thus causing it to become harder to pump blood out of the heart. Think back to the Frank Starling's law. Right ventricular failure can cause peripheral edema. When the right side of the heart fails, the blood is backing up into the venous system. The right side of the heart can fail due to failure of the left ventricle. It can also fail because of cardiac valve disease or an increase in pulmonary vessel pressure, or what's also known as pulmonary hypertension. Chronic obstructive pulmonary disease, or COPD, can also increase the pressure within the pulmonary vessels in the lungs and cause the right ventricle to work much harder. Over time, this can cause the right ventricle to fail. Signs include peripheral edema, jugular vein distension, and liver enlargement. Cardiogenic shock occurs when the heart cannot pump effectively and cardiac output is not maintained. This occurs when the left or right ventricle fails to pump out enough blood to meet the demands of the body. The most common cause for this is myocardial damage that occurs secondary to a heart attack. Less common reasons include sustained hypertension, valve damage, extremes of heart rates, and other cardiac muscle diseases. The patient with congestive heart failure with pulmonary edema can benefit from positive pressure ventilation, such as CPAP. Congestive heart failure is a medical diagnosis that refers to the condition in which there is a buildup of fluid in the body resulting from the pump failure of the heart. It represents the condition in which the left, the right, or both ventricles are failing to meet the body's needs. So with a patient with pure right heart failure, as you can see in table 17-1, their blood pressure will be somewhat normal. Breath sounds will be normal, but they'll have some JVD and peripheral edema. Whereas those with left-sided heart failure, they'll have their blood pressure may be a little on the high side. They'll have rales or that wet sound to their lungs in the upper lungs, but there will be no JVD or peripheral edema. And now the signs and symptoms of failure depend on the severity of the condition and whether it's an acute or long-term problem. They may have severe dyspnea or shortness of breath, tachycardia, suddenly waking at night with dyspnea, fatigue upon exertion, diaphoresis, agitation, edema, abnormal blood pressures, JVDs, distended and soft spongy abdomen, that edema to the lower extremities. Commonly, these patients will tell you that they're taking a water pill, which is just a diuretic that's used to reduce the amount of fluid within the body. You may also find them to have JVD, which would be indicative in patients that are having right-sided heart failure. The heart failure patient with pulmonary edema will benefit significantly from positive pressure ventilation. It will increase the effectiveness of gas exchange by forcing oxygen to cross over the alveoli and the space between the alveoli and the capillary. You may see drastic improvement within the patient's condition following positive pressure ventilation. If the patient has an adequate respiratory rate and tidal volume, administer supplemental oxygen if the patient is dyspneic, hypoxemic, and has obvious signs of heart failure, or an O2 set less than 94%. If the patient is experiencing chest discomfort of any kind and has a prescription for nitroglycerin, administer tablets as per protocol. Nitro can be beneficial to the patient by reducing pressure within the arteries of the body, making it easier for the left ventricle to pump blood out. If pulmonary edema is present or the patient is in moderate to severe respiratory distress, consider the use of CPAP if they meet indications and criteria for use. And then always continuously assess your patient and be prepared for decompensation. Chronic hypertension is different from episodes of hypertension that frequently occur during acute emergencies, often because of anxiety and pain. This type of hypertension typically results from sympathetic nervous system discharge and the release of epinephrine and norepinephrine. Treating the hypertension in this situation is meaningless. The EMT must ascertain from the patient if they have chronic elevations in their blood pressure. You should also evaluate the current blood pressure and compare it to a normal blood pressure for the patient. An elevated blood pressure is often a sign of a condition and not a condition upon itself. So you want to try to identify and treat the underlying cause that is causing the elevation in blood pressure. Cardiac arrest is the worst manifestation of cardiac compromise from an acute coronary event. It occurs when the heart, for any of a variety of reasons, is not pumping effectively at all, and no pulses can be felt. Although cardiac arrest is commonly used by an acute coronary syndrome, it can also be caused by a myriad of other conditions. For example, a traumatized patient may be in arrest following severe multi-system trauma, isolated head injury, or significant blood loss. A person who accidentally or purposely overdoses on their medication may be in arrest because of the effects of the medication. Even a stroke or seizure patient may go into cardiac arrest secondary to the initial emergency. Alright guys, I know this one was a little bit of a long one. Like I said, I'll try to keep them low, but we're going to go ahead and take a break here. Stretch your legs, use the restroom, get something to drink, and we'll be back shortly to pick up with nitroglycerin.